going to be okay.
You'll be fine, inshallah.
In the UK, some 5 million major operations are carried out every year.
Nerves are kicking in now. Good luck, we've got it.
We'll keep you safe, okay?
But some patients' procedures are so complex, only the most skilled surgeons can perform them.
There's adrenaline,
Knife, please.
anxiety,
Lock on, please.
but as soon as you make the incision, everything goes.
Let's focus.
Serving Edinburgh and the surrounding area, NHS Lothian pioneers techniques to treat conditions that few others dare to take on.
You can consider it as a ticking time bomb.
But the cutting edge of modern medicine presents huge challenges.
Every time we operate, there is a risk that things can go wrong.
I'm in difficult territory.
Stop. I don't want to go any deeper than that. I think we'll damage her.
Anything less than perfection
We have a bit of a bleed.
can have grave consequences.
Tube clamp.
The surgeons
It looks very abnormal, doesn't it?
bear the ultimate responsibility.
We can't offer 100% success in everything that we do.
Take that away from me. Give me this, thanks.
You wouldn't be human if you didn't feel the pressure.
You need to be very quick now. You okay?
This is what really happens behind the closed doors
That's a big chunk of the tumour.
of their operating theatres.
You've done something for this person that can prolong their life.
Beautiful. You can see the pulse.
You're waking up, everything's gone really well.
It's one of the biggest privileges
I've got good news.
to help people the way we do.
$48,000 life-saving and life-enhancing operations are carried out across NHS Lothian every year.
St John's Hospital, how can I help?
16 miles west of Edinburgh is St John's Hospital in Livingston, where ear, nose and throat surgeon Ashley Hay specialises in some of Scotland's most challenging cancer cases, removing tumours from the head and neck.
The face of a person is really part of your identity. So I think it is one of the more complex surgical specialties.
Ashley's next case is so challenging, he'll be working with consultant plastic surgeon Patrick Addison.
Ashley is a great colleague to work with. He's very down to earth, he's laid back, but at the same time extremely knowledgeable and capable surgeon who puts everybody he works with at ease.
The 35-year-old patient has a highly unusual life-threatening tumour in her right cheek.
The tumour has grown in and amongst all the nerves and blood vessels that supply the brain.
There's no way to remove the tumour without cutting out a section of her facial nerve, which controls facial movement, including the ability to smile.
So if we don't do our best to reconstruct the facial nerve, she'll have a profound paralysis for the rest of her life.
The surgeons will try to reconstruct the facial nerve, although there's no guarantee of success. Without surgery, her cancer could be fatal within 2 years.
Ready? Whatever number do we need? Number 3. Well, hey, well done.
Becky lives with her partner Callum and their 6-year-old son Innes in the Scottish borders.
This is going to be massive, Innes. Family means a lot to me, and the same with Callum. Innes, he is the best thing ever. He's such a loving boy. He's amazing.
Number 1.
2 years ago, Becky developed pain in her right inner ear.
It was constant pain, and it was pain running down my neck, like shooting pains in my head.
A tumour was found in her right parotid gland, one of 6 major salivary glands. A rare cancer, most often seen in those over 50.
So I think when I heard it was cancer, it's that thinking, I can't have cancer, I'm far too young. Doing a grand job. And you think, oh gosh, am I not going to see him grow up?
It's showtime. What?
Oh.
Try to be positive for Becky and for Innes.
You managed to get an in?
I'm going in, yeah. And we'll deal with it as a family. And it's my job to be there and to help with it.
I don't know what I'm going to look like after. Gosh, what are people going to think? The thought of the surgery gives me the fear, but there's no other option for me. I want to be able to see Innes grown up, and I want to live until I'm 80.
The plan to remove Becky's tumour and reanimate her face requires 4 surgeons from 3 specialisms, each required for critical stages of the 10-hour operation.
This is a complicated operation where we're going into a number of difficult to reach areas. All the nerves from the brain come down through the neck. The neck is also the conduit for blood to the brain. So there are some significant issues that can happen if things go wrong.
To remove the cancer, Ashley must expose Becky's cheek and isolate the parotid gland where the tumour first developed. Then he'll identify 2 branches of her facial nerve for later in the operation, one that closes her eye and one that enables her to smile. Next, because the tumour has grown along Becky's facial nerve towards her brain, a section of skull will be removed and the nerve will be cut. Ashley must next cut the branch of the carotid artery that supplies blood to the parotid gland, while avoiding the branch that supplies most of the blood to the brain. Otherwise, there could be a fatal stroke. Only then can he remove the gland, facial nerve, and tumour as one specimen. To try to restore movement to the right side of her face, Patrick will harvest a nerve from Becky's leg and use it to reconstruct the section of facial nerve that's been removed.
If I don't get this removed, will I see Innes grown up? My face is going to change, I'm going to look different.
Hi there, I've got an appointment. Hello. Thank you so much, Fiona. Thank you. Thank you.
I'm going to have paralysis to my face. Is Innes never going to see me smile again?
Bye, Mom.
Bye.
It's 8:30 a.m. and across NHS Lothian's 55 theatres, operations are starting. At St John's Hospital, in Theatre 6,
We have one case today, Rebecca.
a team of 14, including 4 surgeons, an anaesthetist, and 5 scrub nurses, are preparing for Becky's operation.
She has a right parotid tumour, and the surgical plan today is for a right radical parotidectomy. And we'll then do some facial nerve reanimation.
My fear for surgery is, will I make it? You've just got to put all your trust into the surgeons and hopefully everything will be fine.
So I'm just going to give you that. You just breathe away, okay? You're just going off to sleep. Everything's fine.
Everyone happy? That's nice to see.
First, Ashley makes a 30cm incision from Becky's ear to her neck, through skin and subcutaneous fat,
Okay.
around 1.5 millimeters thick.
So now I think we'll see if we can come into the parotid fascia.
With the fibrous tissue covering the parotid gland exposed, Ashley must try to locate the tumour inside it, more precisely than shown in the scans.
one that feels more down here.
The 5 by 3 centimetre tumour will feel harder than normal tissue.
You need to be able to feed it with your own fingers to be able to understand where you're going to need to cut. I think we can feel the tumour kind of under there. You don't want to cut into it inadvertently, because then there's a risk that tumour cells can escape. It's a hard one to feel though.
There's no margin for error. If cancer cells are left behind, the disease could spread, and Becky won't be cured. Becky's case is one of many complex operations across NHS Lothian that can only be attempted by cancer surgeons working closely with specialists in reconstructive surgery. Taking on one such case at Edinburgh's Western General is consultant urological surgeon Vula Granitsiotis, a specialist in bladder reconstruction.
I can recall when I was about 13 or 14, there were 2 options for my future profession: air hostess or to be a surgeon. So I think I wasn't that glamorous, so I decided to become a surgeon.
Her case also requires the skills of a surgeon she often works with. Bladder cancer specialist, Professor Param Mariappan.
She's a brilliant surgeon. We trust each other. She understands what I'm expected to do, and I know what she's expected to do.
My primary role is not to help people with cancer directly. To put in more simple words, I put things back in rather than take things out.
Their 48-year-old patient has a condition that means Param must remove her bladder, and then Vula will perform an extraordinary operation that will change her patient's life. In Dunfermline, mental health nurse Kay shares her life with her fiancé Dave.
We've been talking about marriage and things, and we sort of decided that we'd do it after my surgery.
After having pelvic mesh surgery, Kay developed pain in her bladder and urethra 5 years ago. The mesh was removed, but her condition has become chronic.
It's pain when you open your eyes. I'm not really able to stand for a mega length of time. I just can't do it anymore. It affects not just myself, everybody.
She's just not as self-confident as she was. You know, that's been really taking a good knock.
Surgeons plan to remove Kay's bladder because tests have shown cells in its lining could become cancerous.
Ordinarily, it has no symptoms until it turns to cancer. But mine's been found, luckily, before that's happened. So yeah, let's get it out and not let that happen. Thank you.
Very good. Found anywhere nice?
Just 75 places.
No.
Kay and Dave are looking forward to their honeymoon, should the surgery go well.
So look, what have we got then?
I found this place. Hopefully the pain from my bladder, that's all going to be gone.
Yeah.
Look at that.
That's nice.
And that's
That is
nice
nice.
day. Which is going to be amazing. Yeah. I'm looking forward to that.
She's got a lining change in the bladder that could become an aggressive cancer. You can consider it as a ticking time bomb.
The surgeons will remove Kay's bladder and urethra to eliminate the threat of cancer and try to reduce her chronic pain.
When are 2 different options. One is to give the patient a stoma bag attached to themselves all the time. So it's leaking constantly into a bag. You can't stop it.
Kay has chosen a more complex option, for which only around 1 in 10 of those who need urinary reconstruction are suitable.
And the second option is to develop some form of internal reservoir. So we utilize this bit of bowel, we isolate it to become a pouch. This procedure is extraordinary because we are removing and changing the function of one bit of their body to something different.
Vula will take a 30 to 40 centimetre section of Kay's 7-metre bowel and transform it into a pouch or reservoir to hold urine inside her abdomen until she chooses to drain it.
She will have the ability to manage their body in a more natural way if she has this pouch rather than if she has to care for a stoma.
Opening up Kay's abdomen to expose her bladder, Param must cut each of the ureters that drain urine from the kidneys. Next, he must isolate the urethra that expels urine and remove it along with the bladder as one specimen. Then Vula will detach a section of Kay's bowel while maintaining its blood supply, or the tissue will die. The section will be opened to prevent pressure building up inside. Once the ureters are attached, it will be formed into a pouch to collect urine. Finally, the tube at one end of the pouch will be narrowed and brought to the surface of Kay's abdomen so she can empty it when needed.
Hopefully the left ureter is going to be without any tension.
I'll definitely try to give you a long enough ureter to join with the other side.
If the ureters are damaged, Vula's reconstruction may have to be abandoned.
There's unforeseen circumstances, surgically either from her bowel or bleeding, that she may have in the stoma bag.
It'll be all right.
I feel quite privileged that I've been given the opportunity to have this surgery. The external bag would stop me doing things, whereas the internal pouch, I can do anything.
There is light at the end of the tunnel. I love you too. She knows there is a fix. Hopefully everything goes according to plan. Right. Come on, right, kick us. Bye-bye.
In the Western General's Theatre B,
Vula, one of the surgeons.
Paramariappan surgeon.
a team of 13, including 5 surgeons, 3 anaesthetic staff, and 2 scrub nurses, is preparing for the complex operation to remove Kay's bladder and reconstruct her urinary system.
I'm anticipating a long procedure.
Follow me.
Thank you. I don't think I can grasp the magnitude of the surgery. Have you been here very long?
I have. I've been here since 2004.
I have to believe that things are going to get better.
Hi.
And then I'm going to give you a teeny tiny bit of the anaesthetic, which will just make you feel nice and relaxed.
Slow deep breaths all the way. Thanks.
Before Vula can start the enormous task of reconstruction,
Knife, please, thanks.
Param will remove her bladder, which can stretch to accommodate half a litre of urine.
So a bit of scarring here. She's had previous surgery.
First, he must navigate the large bowel.
So this is the piece of bowel that Vula will use later on,
which absorbs water from undigested waste.
because we need to mobilize the sigmoid colon, get to the ureters.
Param must isolate both of Kay's ureters, the 3 millimetre wide tubes that carry urine from each kidney, without damaging them.
We know where the ureter is, so you can put 2 clips across the ureter and cut the ureter up.
Each ureter is around 25 centimeters long.
Just going to cut off the ureter since we've isolated it quite close to the bladder.
The left ureter has to be brought across Kay's abdomen to her right side, where Vula will construct the new pouch.
If that ureter was not long enough, we start swinging that ureter higher up, which means we then start encountering the big blood vessels that carry blood into the abdomen. Injury to any one of those could be serious. So I just need a bit of exposure here. Okay. Sometimes we get extra work. I think she's got a duplex. Straight with the clip, thanks.
Param has discovered that Kay has 2 ureters encased in a single sheath on her left side.
It is not a pleasant surprise. So that's the ureter cut off. Both the ureters have their own individual blood supply. Both of these have to be preserved. So we want the fat around it, which contains its blood supply. Again, double ureter on the right side as well.
Fewer than 1% of people are born with duplex ureters on both sides of their body.
If the scan had suggested that there was bilateral, both sides duplex ureters, we may have psychologically prepared ourselves. So we've got 4 ureters to join to the pouch.
More challenging, yeah.
Yeah. The challenge for Vula has just gone up another notch.
At St John's Hospital, in Theatre 6, Ashley and Patrick have exposed Becky's parotid gland containing the tumour.
We really want to lift this further forward now, see if we can find where our branches are.
Running through the gland and tumour is Becky's facial nerve.
It's structured a little bit like a tree with one large trunk and then multiple branches that fan out across the face.
To have any chance of reanimating her face once the nerve trunk is severed, the surgeons must identify 2 branches emerging from the gland. One that closes her eye, the other that enables her to smile.
We've got the nerve stem.
The stimulator delivers an electrical current that travels along a nerve branch, triggering a muscle spasm.
We need to know which branch we're reconstructing so we get the pieces of the puzzle correct when we're trying to put it back together again.
Branch of the facial nerve there.
It can be a little bit like looking for a needle in a haystack.
Yeah. This one looks like it's going to be the best, doesn't it? But if we can stimulate it and just see what it does. I'd like one that's a good smile. Can you see the face, Cliff?
Yeah.
Can you have a look at the eye? Yeah, that's twitching. Yeah. Just feel like it's here.
Yeah.
And just put a temporary marker around the nerves to the eye and then smiling muscles.
Been lucky with my nerves today, haven't I? So
hope you're not using up all the luck.
Yes.
Now, the surgeon's focus shifts to the other end of the facial nerve, its trunk, by Becky's ear.
I think we're just about ready for you, Iqbal.
For the next step in the procedure,
Can we get the lights off?
another surgeon is needed in theatre because the tumour has grown along the trunk of the facial nerve, close to Becky's brain. Iqbal Syed is a skull-based specialist.
That's great. Now I need a size 3 diamond.
He must cut away the 12mm thick mastoid bone to expose the nerve trunk.
You're working very close to the brain, so there's always a chance of causing injury. There is a risk of stroke, there is a small risk of death.
Iqbal has to decide how far along the nerve he can cut.
So Ashley, that's a nerve here. You can see it quite clearly now.
Oh yeah.
So in terms of a healthy facial nerve, we're looking to see a smooth cord-like structure.
Ideally, it would be nice to see where the nerve goes from normal to abnormal.
Yeah, absolutely.
A facial nerve that is involved in tumor is very likely to lose its smoothness, look a bit irregular and a bit discolored.
So I think actually I've got tumor here.
Okay, yeah.
So this looks quite normal here, you can see.
Yeah.
I want to keep as much as the healthy nerve as possible to help Patrick with the reanimation procedure.
This looks fine till here.
Yeah.
And then once I'm here, you can see there are bits of...
Yes, yeah, that's it, isn't
You see
it?
what I mean? There's tumor there.
But at the same time, we want to make sure we don't leave any tumor on the nerve behind.
So what does the scan say in terms of where the tumor extends to?
They can't 100% say, can they? But
neither can I,
Yes.
grossly looking at the nerve,
I have to preserve the nerve. If I don't, then the reanimation procedure will not go ahead.
Patrick, thoughts?
If you're able to divide it sort of halfway up and then send a little bit for frozen section.
Yeah.
I mean, I don't need a lot of stump, just
Yeah.
enough to get some sutures into.
A sample of the nerve will be rapidly tested by the hospital's pathology lab.
it's just going to be put in a pot and sent across.
If the sample comes back cancer-free, the surgeons can be confident all the tumor will come out when the gland is removed.
I think that's my work over for now anyways.
Yeah, perfect, thank you.
Yeah.
At the other end of the table, plastic specialist Patrick is working on Becky's right leg. He needs a section of nerve he can use to reconnect Becky's facial nerve once the tumor has been removed.
Get a little bit bigger.
He is removing the sural nerve, which provides sensation to part of the foot.
The sural nerve is commonly used because removing it has relatively little impact. It leaves this numb area on the outside of the foot.
Right,
To be suitable for the reconstruction, the nerve needs to be at least 15 centimeters long.
Doesn't allow for tension. I don't mind putting them under, but too much.
Coming off Becky's sural nerve are two delicate branches.
So you've got it here.
The reconstruction will have the most chance of working if he can remove the nerve and two branches intact.
No, we could use that to go into the two branches.
Is it 15?
Yeah.
We're going to match.
Finally, the nerve and branches are free.
Short for that.
The bakies, please.
Working on Becky's neck, Ashley faces the riskiest part of the operation.
Follow the carotid up into there. When you're operating in someone's neck, it's not just what you see in one go, but it's the accumulation of a number of small steps. Mark, have you got some artery clips? And you gradually expose a bigger picture.
He is exposing the artery supplying blood to the parotid gland, which must be cut.
I'm going to try and free up the rest of the parotid now.
But the carotid artery has two branches, the other providing the main blood supply to the brain.
Branch on here, isn't it? If that were to get injured or the blood supply interrupted, you can get a stroke.
Together, both branches carry more than half a litre of blood every minute.
Take this. It just takes so much concentration to make the right decision, which is the correct one to cut. So here's our artery going into the parotid. Tie this off now. 2 artery clips, please. Each step that you make, you do your best to know that that's safe.
Ashley's diligence pays off.
Yes, this is definitely this tumour here, you see? We're going to be able to get underneath it, so that's good.
Just as Ashley is about to start removing the gland and tumour,
hello?
There's a call from the hospital's pathology lab.
Okay.
it's not the news they were hoping for.
There was tumour in that frozen Patrick.
To ensure Becky is cancer-free, even more of her facial nerve will have to be cut away.
We'll have to go as maximum as possible on the nerve.
Increasing the risk. She will never smile again.
There's not a lot of room to play with. If I do divide the facial nerve quite high up, reanimation is not going to be possible. Becky will be left with a significant disfigurement of her face, affect her ability to eat, drink, smile. Becky's only 35. It'll be a pretty significant deformity to live with.
For patients like Becky, facial paralysis after surgery can have a devastating impact. At the Royal Infirmary, the Department of Clinical Neurosciences is home to a small multidisciplinary team which specialise in rehabilitation for neurological conditions, including facial palsy.
Facial palsy is the loss of movement, usually on one side of the face. Patients do find it really hard to accept and adjust to the loss of self-expression. I think especially in those early stages with our acute facial palsy patients, it's very rare that I wouldn't have tissues in our treatment room. Joe, this is Claire, who's one of our speech and language therapists.
Jo had a vascular tumour removed 6 months ago and now has palsy affecting her ability to blink and move the right side of her face.
How has it been feeling this last week?
Yeah, it's still annoying and tight, and I'm very aware of the altered sensations.
The face is the first thing you see when you interact with somebody. So as a result, quite often our patients experience quite low confidence and low self-esteem.
I think with each week it progresses, but it feels relentless.
Yeah.
The facial nerve has 5 branches which control muscles in the face. The team utilise a range of exercises to help Jo's recovery.
Maybe just do one more for me until that feels like it's sitting much more naturally. The facial nerve regeneration happens incredibly slowly, about the rate of 1 millimetre a day. As facial nerves regenerate, often the tone in a muscle will become greater on the affected side, so it will sit in quite a tight position, like a coiled spring. Hitting that tight spot again there, yeah. So a lot of our soft tissue work is about trying to regain the correct length of the muscle.
I mean, it definitely feels tight around the cheek here.
So we can see definitely, I don't know if you can feel it, but that lip position now sitting much more naturally.
Yeah.
Like we've said before, it's that spring where you'll stretch it out, it'll ping back in again. So it's just constantly trying to stretch through those muscle fibres, but the symmetry is much, much better.
Yeah.
Helping patients with their self-esteem is probably the most important part of the job. Seeing our patients get back to the things that they love is the reason why we do what we do.
In the Western General's Theatre B,
Harmonic to me, please.
Param is reaching a critical stage in the operation to remove Kay's pre-cancerous bladder.
The bladder is being held by the urethra.
He's releasing the tube that drains the bladder.
It's cutting into the urethra now.
So he can lift out the urethra and bladder together.
That's the specimen.
Now Vula must start the risky and complex process of reconstructing Kay's urinary system.
The moment the bladder is out, there is a point of no return. We have to proceed. The kidneys need to be drained somewhere, otherwise the patient will die. Right? Hello?
Her task has been made even more complicated by Param's discovery.
Bilateral reflex, 4 ureters. So they're both together, see that?
Dealing with the unexpected is one of the attractions to do this form of surgery.
The challenge here is the duplex system. As for what we plug into what.
It makes your brain work. I like challenges.
Fine.
Up to a point.
To construct the new bladder, Vula must isolate a section of Kay's bowel, chosen because it includes a valve that normally controls the flow of waste. She'll open it before attaching each of Kay's double ureters, the tubes surrounded by a sheath that carry urine from the kidneys, making sure the left ureters are freed enough to reach Kay's right side, where the pouch will go. At one end of the pouch, the bowel will be formed into a tube and brought to the surface of Kay's abdomen. The valve will hold urine in the new bladder until Kay inserts a catheter into the opening in her abdomen to drain it.
Okay, guys.
First, Vula must identify a length of bowel on Kay's right side.
That's the bit of bowel we need to more or less take.
It will become the pouch.
The bowel has the elasticity to become a new bladder, but we do need to see the blood supply. If the bowel we take does not have a good blood supply, the bowel wall loses its elasticity and its capacity over time. If I come here, I do have supply.
As the blood vessels can't be stretched, the new bladder must be positioned close by on Kay's right side.
Let's separate a bit here, assuming that's where we're going to go. As far bowel segment, I'm quite happy.
Now, the section of bowel needs to be detached.
Right, guys, 1, 2, 3. We have our bleeding.
One of the arteries in the intricate network supplying blood to the large bowel has been ruptured.
Right, so let's be careful down there. When a surgeon sees a bleed with pressure, you have to control it. Can I have a stitch now, please? The patient can lose significant amount of blood fairly quick. That can cause danger to the patient's life. The problem is that this is a part of our pouch. Okay, can you cut?
Vula is able to control the bleed with a stitch. Now, she can tackle the section which joins to the small bowel.
Yes. Can I have the measurement?
This will form the tube that will carry urine from the new bladder out of Kay's abdomen.
A good 15 centimeters there. So when we're ready?
Vula must reconnect Kay's small and large bowel.
Can you see that I'm going in the right place there?
To re-establish her digestive system.
We will start from here, okay?
Now that it's no longer attached to the rest of the bowel, the section that will form the new bladder must be opened.
Can you hold it in the corners? You don't want to go too far down because you have the valve.
The bowel produces pressure to push waste through it.
Okay, can I have the diaphragm now?
That must be released.
If we don't do that, the pressures that the bowel has will cause the urine to go backwards towards the kidney and cause long-term kidney damage. So you can see that's the ileocecal valve.
Normally, the valve controls the flow of waste through the bowel.
It's actually quite a nice nipple.
But once repurposed, it will stop urine leaking from Kay's new bladder until she chooses to drain it.
Okay.
Vula now faces the most challenging step of the operation.
We need to mobilize the left ureter.
Kay's left ureters must be brought across to the new bladder's location on her right side.
They're not long enough.
But they don't reach.
Okay, let's see what that is. Unfortunately, the ureter's blood supply comes from the surrounding tissue that keeps it also fixed. So that's the challenge here.
Vula has to expose more of the left ureters.
As soon as mobilization, can't see anything. I have to balance reducing the amount of blood supply that goes to the ureter versus not have a free ureter to connect safely with no tension.
But the ureters are buried in tissue welded together by scarring from Kay's previous surgery.
So this is adhesions that we need to get in there. Scissors, please.
The ureter is passing very close to major vessels. They are very difficult when they are disturbed to stop them bleeding. So I have to take extra care to make sure that I don't pull by accident.
I'm in difficult territory.
I need to make sure that it is tension-free. Otherwise, if the ureter becomes narrow, the left kidney could lose function.
So if we have forceps scissors ready for diaphragm in my hand.
At St John's Hospital in Livingston, Ashley, Patrick and Iqbal are about to discover if they can save enough of Becky's facial nerve to allow the reanimation of her face to go ahead as planned.
Wash.
Iqbal must remove even more of her facial nerve because the lab test showed tumour was left behind.
There is a concern that we follow the nerve and actually it will all look abnormal right up to as far as we can get to.
So it's going to divide it here.
I'm hoping that I'm going to leave behind enough of the healthy segment of the facial nerve for Patrick to do the reanimation.
But they will only know for sure if they can attempt to save Becky's smile when Patrick tries to reconnect her facial nerve.
That's me into the tumour now.
That's good.
Now, in order to free the tumour, Ashley must carefully work his way around the edge of the parotid gland.
The bone, come onto the bone. Follow that bone round.
Finally, after 7 hours, Becky's parotid gland, with the tumour inside and a section of facial nerve, are removed.
It's a really nice feeling.
There we go. We hand that off.
Sometimes it feels a bit of a battle of you versus the cancer. And so it's nice to know that that bit's done. Great, we can swap over.
After the easy bit.
Yes.
To try to reanimate the right side of Becky's face, Patrick must use the nerve he harvested from her leg and reconnect the trunk of her facial nerve to the branches that enable her to close her eye and smile. Success is far from guaranteed. The shorter the facial nerve trunk has been cut, the more the fibers inside are mixed up, creating a risk she might smile when she tries to close her eye.
That's the end of the nerve there.
Patrick reconnects the stump of the facial nerve, close to Becky's brain, to the branches Ashley left intact in her cheek, to try to save her smile.
Okay, can I have the nerve, please?
So the facial nerve at the trunk is about 2 millimeters in diameter, and the sural nerve that we've harvested is also about 1.5 millimeters, which is why we do the work under the microscope.
Okay. Can I have straight, sharp scissors and microforceps?
First, he will cut the new nerve to fit the gap between Becky's facial nerve trunk and its branches.
You've got ample at the front end, haven't I?
Yeah.
Joining the two nerves is far from straightforward. Patrick must make stitches in the epineurium, the sheath just millionths of a millimeter thick that encases the nerve fibers.
So what we're trying to do is repair the sheath around the nerve, a little bit akin to the plastic wrapping around the electrical cable. It doesn't need to be perfect, but it needs to be as close as we possibly can.
Can you cut it here for me?
Patrick has to get 4 stitches into what's left of the trunk.
Don't wobble the cable there.
If the join is to hold.
How are you finding it, Patrick?
It's a little bit short in there.
It's
stump, but it's just enough, just enough.
It's not going anywhere, is it?
Patrick has managed to attach the new nerve to Becky's facial nerve stump. But he has 2 more connections to make.
Straight micro scissors, please.
To 2 branches of Becky's facial nerve that are even smaller, a fraction of a millimetre in diameter.
Actually, let's go for a 9-0 after all.
First, the branch which enables her to smile. Then, the branch which helps close her eye.
I'm going to have to hold that ear up away, one of you.
Okay.
The facial nerve trunk has been cut very close to the brain.
Can you cut that bit then?
And so there's a risk Becky won't be able to control her smile.
I don't have a huge amount of faith in this one.
Because we're putting a nerve graft very high up on the facial nerve where the nerve fibers are all mixed up. It's impossible for me to distinguish which of those fibers is meant to go to her mouth or to her eye. So when she tries to close her eye, she might smile.
To try to solve the problem, Patrick has an ingenious solution.
2 branches so we can leave one going to the masseter.
He takes a branch of the nerve that controls the muscle Becky uses to chew.
We'll just let it take its tension.
And connects it to the second branch that controls her smile.
This is a belt and braces approach. She'll initially at least have to clench her teeth in order to get the smile muscles to move.
With all the connections complete,
that should be pretty good, hopefully.
Patrick's done everything he can to try to preserve Becky's ability to smile.
We can close up.
There's one final task.
When you have a facial paralysis, your eye tends to stay open.
He takes a gram of gold, chosen because it's heavy and well tolerated.
Drop that in underneath the skin.
We typically put a weight into the upper eyelid, so when Becky turns off the muscles to open her eye, then gravity will take over.
It's taken a team of 4 surgeons 10 hours to remove Becky's tumour and reconnect her facial nerve.
Hi there, is that Callum? We're just about finished and we're really happy with how it's gone.
Yeah, I'm grand.
But it will be many months before they'll know if the crucial nerve fibres have successfully regrown.
We'll be fantastic.
And if she will smile again.
Can I give you that to hold?
Vula is nearly 4 hours into the operation to rebuild Kay's urinary system after her bladder was removed.
But the problem is the left.
She's trying to work out where exactly the left ureters should attach to the new bladder.
So the 2 left will be somewhere in this bit, but he can go here, so the ureters will go there.
But it's a struggle.
This is the difficult one. The left one is the difficult one. Two sort.
The success of the operation hangs on whether the left ureters can be attached.
Okay, as a moment of truth.
Without any tension.
I'm going to make a hole here. I'm going to have the 2 ureters to come together as they are. I know I don't have many chances making holes in the bowel. Are we straight here? I don't want to get lost. Many holes means many more areas that can leak urine as the patient is recovering. Yes, we agreed? Okay, right, 1, 2, 3.
Now Vula can attempt to stitch the ureters to the section of bowel that will form the new bladder.
Guys, this is difficult.
The left ureters just reach.
You see the hole in the middle, so you should be bringing urine out.
The right ureters are attached to a second hole.
I feel a sense of relief because one of the technical and difficult parts of the operation is finished.
Right, guys, let's go.
Next, Vula brings the sides of the new bladder together.
So that goes on the top. So this is the side. I'm going to close that this way, otherwise too much pressure. We are closing the pouch, okay?
The section of Kay's large bowel has been transformed into a new bladder.
That's pouch up there, closing.
There's one final challenge. Positioning the new bladder to make sure it can drain urine effectively when a catheter is inserted.
This is the critical thing. That's the pouch. So this is the catheterizable stoma. So the pouch needs to go low down. So we put this up here, about there. Yeah?
Now the tube that will drain the new bladder must be brought to the surface of Kay's abdomen.
We'll get that stoma straight out. As we said before, we will possibly need to cut it there.
The important thing for Kay is that she's able to control the empty of her pouch.
So we put this up here.
So the knit tube is as straight as possible.
That we pass it out first.
So when Kay is going to put a catheter through it to empty, it has to be as easy as possible.
That's the needs to come up, okay? So we're agreeing that the easiest thing to do is to bring it here. Because if it goes further up, it's not going to go straight. Last chance. You need to be straight. You need to pull it that way. Okay, let's go again. Okay, don't over pull it because I just don't know if we are stretching too much. Okay, go for it.
I need to balance the desire to get the tube out versus damaging accidentally the blood supply when I'm pulling it.
Any ideas?
Unable to get the tube through the stomach wall.
Need some help, Vula?
It needs more straight.
Vula consults fellow surgeon, Param.
I feel that having another pair of eyes is important.
It just doesn't come up on this bit.
Let me just guide it through.
It's almost done. Oh, okay, thank you very much.
It's a pushing movement rather than a pull.
Thank you, Param.
I am grateful for his opinion and I'm grateful always for his experience. Hence, we always tend to work together.
Yep, excellent. All right, let's close.
It's taken 5 surgeons more than 10 hours to remove Kay's bladder and give her a urinary system she will be able to control.
The first time I have duplex system in this situation.
I think we've done, under the circumstances and the difficult situation, the best we could on the day. I wouldn't have changed anything.
Okay.
I'm happy with the way things develop.
It will be 6 weeks before Vula knows if the operation
All right, good to go.
has been a success.
What were you doing at school? Boring stuff. Maths.
Boring.
4.5 months since her surgery, Becky is adapting to the gradual progress of her facial nerve recovery.
There's no movement on this side, so I do struggle to talk out this side. But I feel as it's went on, it's got much better. Come on, slow coach.
Since the rare tumour was removed from her cheek, Becky's had radiotherapy to try to prevent the cancer returning.
Hopefully I can live cancer-free. It means the world to still be able to be a mum to Innes and a partner to Callum and to still be here.
Oh, we've got to help Mum down.
You have to help me.
You never know how long you have that time together, so you've got to enjoy it while you have it.
Look.
There it is, see? You see it splashing?
Yeah, I can see the bubbles.
Before her operation, Becky had been worried that 6-year-old Innes might not see her smile again.
When Innes came to see me, he didn't even seem that bothered. And even now, he touches my face and he's like, oh, can you feel this? Which one's the sore side? Kids just adapt, is it?
Yes.
Over the next 2 years, the new nerve fibres in Becky's face should continue to grow, giving her more movement.
I'm hoping in future that I might be able to get a bit of a smile back. Who knows what it'll be like in a year's time. Would you like that? Yes. If I could smile again? Yeah. On both sides?
The ability to smile is incredibly important. If you can't smile, you tend to withdraw from society. And so in Becky's case, it's very satisfying to give her a chance of having a normal smile.
Let's head out.
Thank you.
3.5 months after her operation, Kay's new bladder is working well.
My bladder pain has certainly gone away. It's just getting used to the new normal. Feeling well enough to come up for a little wee while. It's good.
Currently, Kay has to empty her new bladder by inserting a catheter into the hole in her abdomen every 2 hours.
The catheterization itself isn't painful, but there's definitely a knack to it.
Over time, the pouch should stretch to hold around 600 millilitres of urine, so Kay won't have to empty her new bladder so often.
Didn't think I'd be walking around here a couple of months ago.
It's nice to have the new Kay back. She's smiling a lot more. With Kay being happy, it means a heck of a lot to me.
In the next few months, Kay and Dave are planning to get married.
The future's looking really bright, so it has given me a new lease of life.
I'm quite at awe on my predecessors, my colleagues, that they have managed to understand rearranging the body to have a bit of the bowel suddenly to become bladder for the good of the patient's life.
Next time, Hearts and Minds.
Okay to start?
Surgeons tackle complex cardio.
I think the heart is the most important organ of the body. It's basically life.
And microscopic brain surgery.
There is this eternal question of neurosurgeon, remove or not to remove.
Stop. Don't want to go any deeper than that. I think we'll damage her.